It's a great pleasure today to have Mary Jo Pugh, who's an epidemiologist and a registered nurse and a research career scientist at the VA in Salt Lake City and professor of epidemiology at the University of Utah. Her topic today is mild TBI diagnosis and management strategies concerning the phenotypes of comorbidity in mild TBI. Mary Jo?
Thank you very much. It's very nice to talk with you all. The one thing that I do want to emphasize right now is that I am as interested in what you have to say as what I have to say to you. Actually, I'm more interested in what you have to say because it will guide the work that we're doing in the future. So when I joined the Air Force as a nurse in 1984, I never dreamed I would work as a researcher, and I particularly didn't think I would be working at the VA or that the work I do now would be focused on TBI. And you may ask why. But on a sunny day in May of 1985, I was training for a triathlon. I was riding my bike on the shoulder of State Road A1A near Patrick Air Force Base when I was hit from behind by a drunk driver. I was unconscious for 5 hours, but I made a rapid recovery, and that was that. I just assumed that everyone with a moderate TBI like I experienced had a simple recovery process. It turns out that's not true, and that's guiding the work that I do today, which is I find to be very exciting. Today, I'm going to be describing results of the chronic effects of neurotrauma consortium epidemiology study, which used what I call the warfighter cohort. I have no conclusions, and everything I say today is my own opinion, and no official endorsement should be inferred. So today, we'll begin by describing comorbidity trajectories, why it's important to study them, and then followed by some results from this chronic effects of neurotrauma consortium warfighter epidemiology study that identified comorbidity trajectories in veterans who were deployed in support of post 9/11 conflicts, including the relationship of those trajectories to a variety of different outcomes. We'll end today by talking about limitations of that work and outline the extension of the work that we're doing now in the long-term impact and military relevant brain injury consortium. But I'm also very interested in your thoughts on how we can make our work going forward better. So I'm sure most of you are familiar with the signature injuries of post 9/11 conflicts of mild TBI, mental health conditions, and pain. And these conditions are often caused by blast exposures, and that many studies have examined epidemiology and outcomes of one or two types of these conditions, and sometimes have examined all three, such as Henry Liu's description of the polytrauma clinical triad, which he defined as TBI, PTSD, and pain. But given that there are over 400,000 service members diagnosed with mild TBI over the past 2 decades, and many more experiencing mild TBIs that are undocumented, it's critical to better understand the trajectories of health and recovery of those with TBI. Now, studies using traditional logistic regression and Cox models have found associations between TBI and headache, depression, substance use disorder, suicide, and other work has found that TBI in conjunction with depression, PTSD, or substance abuse is more strongly associated with those outcomes. But these findings suggest that among those conditions that occur over time, that there are patterns, and yet examining outcomes such as with a logistic regression or Cox model doesn't use the vast amount of information that's available in longitudinal health system data. And so why is that important? Because TBI, which has previously been defined as an event, has been redefined in recent years, particularly by Maisel and DeWitt in 2010, as a chronic disease. Why is that? Well, TBI fits the World Health Organization definition of chronic disease. I got to get a lot of dog out. I apologize. Chronic disease by having one or more of the following criteria. It's permanent. It's caused by non-reversible pathological alterations. It can require special training of the patient for rehab, or it may require long periods of observation, supervision, or care. We know from decades of research that TBI increases long-term mortality and reduces life expectancy. It's associated with the increased incidence of seizures, which I do a lot of work studying, sleep disorders, neurodegenerative diseases, endocrine dysregulation, and psychiatric diseases, in addition to non-neurological disorders such as sexual dysfunction, bladder and bowel incontinence, and systemic metabolic dysregulation. We have a large and growing literature that's identified predictors of good and bad outcomes after TBI, and a smaller and growing literature that's describing these trajectories of recovery after TBI. And we believe that both types of research are important for understanding. Now, looking at what are the differences between outcomes research and trajectories. So outcomes research typically includes a baseline characteristic, some injury characteristics, and either an outcome at some later point or a comparison of early measures of function with later function. Now, this figure shows that analyses of trajectory of recovery, which are less common, but increasingly more common as data become available. But one of the critical features required for developing trajectories is the availability of longitudinal serial measures. To develop a trajectory, we need outcome measurement of at least 3 or more points in time. And more data points allow a more detailed evaluation of trajectories. And the length of time between measurements is also important. For instance, 3 or even 5 outcome measures in a week is less valuable in many ways than 3 or 5 outcome measures that occur over the course of 1 to 5 years. We believe that understanding longer-term health trajectories will help improve clinical care by first identifying individuals at risk for adverse outcomes early in the course of care, by identifying resources needed to provide optimal care, and to understand in this context military characteristics and exposures that are associated with different types of what we call phenotypes. We believe also that this preliminary work that I'm describing today will help us to provide information to build more prognostic models that can be used by clinicians at the bedside with something like a dashboard that could be developed using informatics methods. So turning to the Sensi Warfighter study, the goals of that study were to use longitudinal VA health system data to examine patterns of comorbidity, which we'll call, going forward, comorbidity phenotypes in this post-9/11 veteran population. And we did that stratified by TBI severity, and we did that during the first 5 years of VA care, so everybody would have the same amount of follow-up. We identified also adverse outcomes associated with specific comorbidity phenotypes so we could see if those phenotypes had any predictive value. So today we're going to review the results of this study, which were published in PLOS One, and another study published in the Journal of Head Trauma Rehab over the past 18 months. So this study was a retrospective cohort study in which the cohort was identified in VA data. We identified common post-concussion, post-deployment related symptoms and comorbidities for each year during the first 5 years of VA care. And using those data, we conducted latent class trajectory analyses of comorbidity over time stratified by TBI severity. The majority of the findings today are focused on mild TBI compared to no TBI, but we do look briefly at some of the commonalities when we look at all of the TBI severity strata. We identified individuals who were previously deployed to post-9/11 conflicts using the OEF-OIF-OND roster, which is derived from the Defense Manpower Data Center. We then identified individuals who entered VA care before the end of fiscal year 11 and who received care at least once a year for 3 years between fiscal year 02 and 14. The years of care, for your just FYI, didn't need to be consecutive because if you do that, then it selects for the most severely affected. There are some limitations to not requiring consecutive care as well. In order to identify individuals with mild TBI that might have been identified using the screening that started in 2007, we also required that each individual have care at least once in 2007 or after, which allowed us to then make sure everybody had the same opportunity for screening that might identify a mild TBI that occurred in deployment status. So then we also obtained the DoD trauma registry and the health system data from the VA and the DoD. And the VA data included the TBI screening and comprehensive TBI evaluation in addition to inpatient, outpatient, and pharmacy data. Because it took some time to obtain the DoD data, though, we used that data to understand the differences among the trajectories that we identified in VA care. So using the data that we had compiled, we identified TBI severity, as shown in this figure, beginning with the DoD trauma registry. And we call this our all sources TBI severity algorithm. So for those people who had data in the DoD trauma registry, we first used the Glasgow Coma Scale score. Because of some data irregularities pointed out by our DoD colleagues, for those with a Glasgow Coma Scale of 3, which is pretty much pretty close to dead, we deferred to the ICD-9 codes or other available data. And in part, sometimes when you have a very high tempo injury flow coming in from the field, people might document a Glasgow Coma Scale score and just move on if somebody was sedated for a severe injury. So now those without DoD trauma registry data, we use data from the first source of data we used was the VA comprehensive TBI evaluation. And we did that because it included self-reported loss, duration of loss or alteration of consciousness, and post-traumatic amnesia. So that allowed us to identify people who, based on the ACRM criteria, had mild versus moderate or severe TBI. And it wasn't finely grained enough to really go beyond combining mild and moderate TBI. So for those without data then in this CTBIE, their comprehensive TBI evaluation, we then used ICD-9 codes. And we used the algorithm used by the Armed Forces Health Surveillance Center system for TBI severity. And then we looked at the TBI screening data for people who had no indication previously of a TBI. And we thought it's important to do that because sometimes people have a TBI and it resolves. And in fact, the majority, about 80 to 85%, have a quick resolution of mild TBI symptoms. And so people who reported having a deployment-related head injury with loss or alteration of consciousness or post-traumatic amnesia, and who had post-concussive symptoms such as nausea, vomiting, dizziness, headache after the injury, and who reported having post-concussive symptoms in the last 2 weeks, but didn't have a diagnosis of TBI, were considered a screen positive with no TBI diagnosis. And then we further identified those folks who had the head injury, the loss or alteration of consciousness or post-traumatic amnesia, and early symptoms, but who did not report the persistence of symptoms in the last 2 weeks. And so we call those historically resolved TBI. Now, using VA inpatient and outpatient data, we identified the comorbidities or the conditions on the slide, we identified those diagnoses each year, yes, no, for the first 5 years of VA care. And the conditions here are those associated with mental health, possible TBI sequela, pain, and then weight and sleep. Using these dichotomous variables over time, we then conducted latent class trajectory analysis, which is a method that groups people with similar patterns over time. We did the analysis stratified by TBI severity. In this case, we're going to focus on mild TBI and no TBI because those are the two largest groups. We selected the best fitting model for each TBI strata based on the AIC and BIC, and then evaluated those patterns based on from a clinical lens to make sure that they're clinically meaningful and to characterize each pattern. We identified the most likely class for each individual using the pseudoclass technique. Now, our latent trajectory analysis revealed 5 classes for the no TBI and mild TBI. And among those classes, as you can see, 2 of those were similar. We'll look at these 5 classes for mild TBI and no TBI in a little bit more detail. And then on the following slides that we look at this detail, we'll present the probability of any individual in the class having a specific comorbidity. We focus on just year 1 and year 5 so we can actually see the difference between year 1 and year 5. The patterns between are kind of linear for the most part. The line that you're going to see in the next few slides with the lighter hue is year 1, and the line in the darker hue is year 5. The specific conditions are presented on the x-axis, and the probability of having one of those conditions is presented on the y-axis. Now, this slide that says healthy, it is interesting to note that there was no healthy trajectory or phenotype in the mild TBI group. It only occurred in the no TBI group. This is characterized really by a minor blip in other pain, which is musculoskeletal pain, primarily arthritis, a little bit of hearing loss. And the next group shows two graphs indicating a moderately healthy trajectory. It's or sort of healthy. It's really not a whole lot going on, but there are indications of tinnitus and hearing loss and pain, but little indication of other comorbidities, at least not at the same level as the population base rate. We also found in the mild TBI group that there was this sort of healthy, moderately healthy group that deteriorated. So in year 1, it looked very much like the other group. But by year 5, we see significantly increasing depression, PTSD, other, pain, back pain and neck pain, headache in particular, and cognitive complaints, which are based on a diagnosis. It's indicative of dementia, but we know that in this population, it really is associated with complaints of cognitive issues and memory, and then some insomnia. And then the next pattern we saw was a similar trajectory, the similar pattern, but not the same magnitude, that's characterized by high mental health and substance use disorder here, and and also some other mental health, so PTSD, depression, anxiety, and then a little bit of pain, but not dramatically high rates of pain or probabilities of pain. So the pattern's similar, but the probability of each of these mental health and substance use disorder conditions is higher in the mild TBI compared to the no TBI group. And next we see that in the no TBI group, there was a group that just had some pain going on. We did not see that in the mild TBI cohort. And then we found 2 polytrauma phenotypes. Our prior work had really just found one, but when we disaggregated into more homogeneous groups such as mild TBI, you can see some distinction among the groups. And so this group on the left shows, you see the year 1 had pretty high rates of tinnitus, hearing loss, PTSD, substance use and depression. A lot of the pain and the cognitive dysfunction and the insomnia were much higher in year 1 than year 5, much higher probability. And so we call these polytrauma with improvement, and the group on the right looks pretty similar with a little bit of elevation of likelihood, except for tinnitus and hearing loss, which once diagnosed, there's really not a whole lot you can do about that, so people don't get that diagnosed over and over again in general, unless it's a very severe issue. Then, so we took those phenotypes and we looked at what kind of things did we see in DOD data prior to that. And what we're going to show you here are the 2 polytrauma phenotypes, and then kind of look at the polytrauma with improvement and try to see what distinguishes this moderately healthy and the moderately healthy with deteriorate. So those who had deterioration in this moderately or sort of healthy group were less likely to have served in the National Guard or Reserve and less likely to have multiple deployments. They were more likely in DOD data to have a TBI diagnosis, to have mental health diagnoses, and to receive what we call CNS polypharmacy, which is 5 or more CNS active medications in a year. And looking at the polytrauma versus the polytrauma and improvement groups, we saw that those with improvement were contrary, less likely to have DOD, TBI, or mental health diagnosis, less likely to have those CNS polypharmacy, and they were more likely to have multiple deployments. So it's almost the flip side of the same coin, but with a different extreme. Then the question is, so what? So in order to see if these trajectories had clinical impact, we examined these adverse outcomes of suicidal ideation, attempt, homelessness, and mortality so after the trajectory development period, so in year 6, 7, and 8, and mortality through 2017. Actually, the outcomes were in year 6, sorry, so everybody would have the same opportunity to have that outcome identified if it happened. And so we found that the highest rates of suicidal ideation and attempt and overdose were in this mental health and substance use disorder. and the lowest were in the polytrauma with improvement group. So there's something about this improvement that made them even less likely than the sort of healthy group to have these adverse outcomes, and that included mortality, which we had on everybody. So then we conducted a logistic regression analysis and controlled for other kinds of characteristics, and we found that compared to the moderately healthy group, the polytrauma and improvement group was significantly less likely to experience overdose, suicidal ideation, or attempt, and it was slightly less likely to also experience mortality. But you can see here that this mental health and substance use disorder is much higher than all other groups on overdose. So to better understand these findings, we then linked the trajectory data with neurobehavioral symptom inventory data for those individuals that also had data in the VA comprehensive TBI evaluation, which was about 79% of the mild TBI cohort. So the NSI, if you're not familiar with it, you probably are, but if you're not, it's a 22-item scale that has 4 subscales. It has an affective scale, a cognitive scale, a vestibular scale, and a somatic sensory scale. And there's also a single item measuring interference of symptoms on daily life. We identified high burden on each scale as a mean of 3 or above, which reflects severe or very severe symptoms or interference. We found again that this moderately healthy group scored best on all measures, and this was followed by a polytrauma with improvement group. And the polytrauma phenotype here had the highest reported symptomology and interference, even significantly higher than this mental health with substance use disorder, which had kind of worse outcomes that were related to overdose and suicidal ideation or attempt. And also the decline group, that the folks who had moderately healthy with decline were actually quite similar to the mental health and substance use disorder on these self-reported symptoms that were developed in clinical care. So then we conducted a logistic regression analysis for each of the scales and found that the polytrauma phenotype was significantly more likely to have high burden symptoms across all of the scales compared to all of the groups, and that the moderately healthy group scores were significantly lower than all other groups. Of interest, though, the moderately healthy and decline group was significantly more likely to have high burden symptoms across all subscales and interference. And this moderately, the mental health with substance use disorder group, right, mental health, yeah, the mental health with substance use disorder group had much higher scores than the polytrauma and improvement group on cognitive, affective, and interference measures. So not so much different on vestibular or somatosensory, but significant differences on cognitive, affective, and interference. And this moderately healthy with decline group didn't look that much different. I mean, it looked different, but it was somewhere between this mental health group on the cognitive and affective and some of the other groups. So it definitely demonstrated kind of high symptom reporting on all of the scales and interference. So together, all of these data suggest that our comorbidity trajectories effectively identify individuals with different symptom experiences and different rates of adverse events. So they might be helpful in a clinical setting. But another question is, are these similar across TBI strata? And so we found that there were some, but not all. And I'll show you what the kinds that were similar across the strata. So for all of the TBI severities of penetrating TBI, moderate, severe, mild, unclassified, the screen positive and the historical resolved, all had a cohort, had a phenotype of moderately healthy, where there was some stuff going on, primarily pain and obesity, kind of with like you might see in a middle-aged cohort that were relatively healthy. But each also had what we call mental health and high substance use disorder phenotype. And we're going to look at that in a little bit more detail now. Of interest to us was this historically resolved group. And we kind of parsed these folks out because we thought it was an important thing to identify, because based on TBI screening and comprehensive TBI evaluation, these folks would not even be considered to have had a mild TBI, but based on their clinical history, they experienced a head injury, they had loss or alteration of consciousness or post-traumatic amnesia, and they had symptoms afterwards. They just had their symptoms resolved. And so this is the smallest group. It's a relatively small group in this cohort, but they also had, and they had the smallest percentage of individuals with this this high substance use disorder trajectory, but they had actually the highest probability of having substance use disorder compared to all of the other strata of TBI. And so you see, of interest here also that this is a substance use disorder probability. It's actually less than the PTSD probability, which is different than all the other TBI strata, which you'll see. So the folks who screened positive but didn't have a TBI diagnosis had about 19%. They had 19% of the cohort fit this strata, this phenotype. And as you'll notice in all of these following phenotypes, the PTSD probability is higher than the substance use disorder probability. And in each, the substance use, all of the mental health and the substance use disorder probabilities increase significantly from year 1 to year 5. Now, the unclassified TBI group, again, about 20%. And by year 5, nearly 50% had a nearly 50% probability of having a substance use disorder by year 5. Mild TBI, we already saw that. It's a little bit less than 50%. And the moderate and severe TBI was around 50% by year 5 and started around 30%. Penetrating TBI was a little bit very similar to the moderate and severe TBI, but all of these had about a 20% probability, about 20% of the TBI strata fit into this high substance use disorder phenotype, except for the historical resolved. So it's a pretty good chunk of all of these TBI strata, and it also is the same for the no TBI. So what does it mean clinically? I actually think these results lead to more questions than they answer. I do have some thoughts, but I'm really very interested in your thoughts on what these mean clinically. So what we do know is, with regard to TBI severity and the trajectory of mental health and substance use disorder, each of these strata is associated with a high probability of PTSD that kind of goes along with the substance use disorder. And so one might hypothesize that getting veterans into treatment for PTSD and probably depression as well may lead to lower risk of substance use disorder in the long term. Unfortunately, we don't have those data quite yet, and we're looking at that. This question, though, from our team was highlighted by the findings for the group that was screened positive for TBI exposure with initial post-concussive symptoms that were resolved. This group had the highest probability of substance use in year 1 and in year 5. And the question is, are these folks who have this very high probability and don't go through the TBI screening, that after the TBI screening process, they are probably not so much in the polytrauma system of care? Do those individuals fall through the cracks? Or is there additional exposure information that might help to inform which of these veterans in this historical resolved TBI are at highest risk for substance use disorder? We don't know that, and we're evaluating that right now in the follow-on to this study, the LIMBIC, Long-Term Impact of Military Relevant Brain Injury Consortium. So in conclusion, we've used these longitudinal health data to help us understand trajectories of comorbidity. Some of these trajectories show improvement, which we had never actually seen before, and those trajectories that show improvement are significantly associated with better outcomes. We need to be able to figure out early on which people who look like they're doing okay at the beginning improve or get worse, and likewise those who look like they're in this polytrauma triad or the polytrauma phenotype, which ones improve or get worse. And so we did also see that there's meaningful variation by TBI severity, but we also know that this is just a first step. And in part, it's a first step, mostly because we have more data available now and there's so much more to learn. So our trajectories were developed using only VA data, and we know there are key pieces of information that will likely inform what can be seen in VA data. And once we take the data from DOD and merge with VA, which we're doing right now, we'll have a longitudinal record of health that extends significantly beyond what we can see in VA data. In addition, we only use diagnosis data in our initial study, and we know from another recent study that integrating medication and procedure data with diagnosis data allows a new window in understanding trajectories that's more informative and more sensitive. We focused only on TBI-related TBI that occurred in a deployment setting, so we're not actually sure whether what we see is generalizable to non-deployment TBI, or if there are critical pieces of the deployment setting that result in these specific phenotypes and trajectories. This is really important because the majority of DoD TBI, like my own, occurred in a non-deployed setting. And so if we can parse out the deployed setting and the non-deployed setting, that will give us some sense of the unique contribution of a deployment-related or combat-related TBI to outcomes and trajectories. And finally, these results, while they are really interesting, are really quite descriptive. And when I started doing this, I thought they were amazing. But as I look back on what we're doing now with our extension of this study, the Long-Term Impact of Military Relevant Brain Injury Consortium, these phenotypes are really kind of like a chi-square of multivariable data. And so we can see patterns and we can identify people who ultimately have a good or a less optimal outcome. But what we really want to do from a clinical perspective is focus on who within this, who when we look at the starting part of the data, who's likely to progress down a road of decline and who's likely to improve. And that will allow us to identify targeted places for intervention and possible interventions and help identify possible interventions that lead to better outcomes. So these limitations, luckily for us, can be addressed in the extension of this work, which we call the Limbic Sensi Phenotype Project. And we'll seek to identify the risk for decline and improvement in these phenotypes, and then also identify risk or risk scores for specific comorbidities of interest. And based on what we know right now, we obviously believe substance use disorder is important. Also mental health conditions and self-harm conditions, but looking at it from a neurological perspective, the neurodegeneration, we have a longitudinal data that we can begin to look at who early on, what kind of data early on predicts a neurodegenerative outcome. And then other chronic diseases are increasingly important as we see that cardiovascular disease in a recent study was found to be significantly associated with dementia in an elderly veteran population. So we want to look at the longitudinal perspective on TBI, chronic disease, and other kinds of outcomes such as neurodegeneration, cognitive impairment, that kind of thing. And we can do that using DoD and VA health system data. Our risk models will include all of the things that we didn't have before, not just diagnoses, but also medications and procedures from both DoD and VA care. And we can use things like mental health screening scores so that we can identify individuals who are at risk earlier in their care so that we can help mitigate that risk. We're also going to look at non-deployed personnel and data from those who don't matriculate to VA care. So just looking at those who don't matriculate and their DoD care, so we can compare those who do and do not matriculate and see what can we generalize to veterans from this cohort and what can we say is really unique to veterans who are in VA care. We'll be using all kinds of amazing machine learning approaches that I don't know how to do, but I have a great team who can do that. And then those approaches will be used to identify risk scores for substance use disorder and all these other kinds of things that we're interested in examining. And then I'm interested not only in your questions or discussion, but what would you like to see us look at going forward as well? And that's all I have.
All right. Thank you, Dr. Pugh. We have a few questions lined up right here, and I'm just going to go in order. Do you have a sense of how much engagement in therapies influence the phenotype presentations?
I don't. That's a very good question, and one that as we use the more sophisticated serial machine learning approaches on the data, we can do. The approach that we used previously did not allow us to examine that. Are you interested in engagement in, say, PTSD treatment? And I don't know, I'm not sure if that can be addressed to the person asking the question.
Okay, we'll see if they follow up on it. We'll just move on. Our next question, any effects of treatment of the deteriorating phenotypes?
And that's, I think, from Dr. De Palma. Is that effects of treatment on the emergence of deteriorating phenotypes, or the effects of treatment in the deteriorating phenotypes of improvement? I think that's either way. We know that people who have a lot of treatment, as far as medications go, tend to go down the deteriorating hole. And I think that's probably really a confounding by indication. So people who have more symptoms and have worse problems tend to get more treatment. And so that's a difficult problem to solve, but one that we'll be looking at in our next steps of the study. And if you have other questions that I didn't address, Dr. De Palma, please bring those out.
All right, thank you. So this next one, Dr. Pugh, thank you for the presentation. Have you been able to delineate single versus multiple TBIs within any of these data sets and associated trajectories? Furthermore, are you able to link these trajectories to any clinical biomarkers available within charts, CRP, to speak to mechanism underlying distinct trajectories, example, prolonged inflammatory responses?
Yeah, no, that's a great question. We have not, in part because the way that TBI was identified is not easy to determine the number of TBIs that people have in the health system data, in part because many of the TBIs are never documented, so the mild TBIs frequently aren't documented. Probably no different in a VA or DOD setting. I think the screening processes probably make that better, but those are not necessarily documented in anything more than notes. We are evaluating the feasibility of doing natural language processing to do that. I am not sure if I'm hopeful for that or not, but we're looking at that in another study. And then looking at clinical biomarkers, this is something that's very interesting to me, and this is part of why in our limbic study we are adding additional data fields. One of those is radiology reports that we can look at to see if they have normal or abnormal radiology reports. And the CRP, the C-reactive protein, is one of the many kinds of lab results that could be feasibly linked to this to help identify prolonged inflammatory response. Another approach, and something that we're trying to work with our friends at USU, Uniform Services University, is to link our trajectories, the people in specific trajectories. Maybe you certainly couldn't do them all, but you could target, people in the high and low, or the decline and not decline, and improve and not improve, looking at samples from the DoD serum repository. Timing of that is a little bit iffy too, so that's something that would take an entirely different study that we're hoping to do that at some point in time. It'd be really interesting if someone could link this with the MVP project. So.
Thank you. Our next question is, does your data set include serious TBI with visible head injuries, veterans who are not cognitively impaired regarding SUD and MI?
So I would suspect that many of the penetrating TBI folks, it's a small group, many of them would have visible head injury. I'm trying to remember everything that you said. Visible head injury without cognitive impairment and substance use disorder. So I would say yes, there probably are some. I think we'd have to look at them and parse them out. But yes.
Thank you.
Yeah, go ahead.
Okay, and then this is a follow-up to the first question about the phenotype presentations. This person says, I provide cognitive rehab, so I'm very curious about how much therapies influence these phenotypes or vice versa. This kind of specificity of TBI diagnosis is very much needed. I really appreciate this presentation and line of work. We need specificity similar to what they do with cancer staging, not just coarse-grained categories of mild, moderate, severe.
Agree.
Yep.
No, I totally agree. And I was recently doing a lit review on identifying phenotypes of TBI severity, and there's a lot of new research coming out, and that has been done probably in the past 3 to 4 years, and there's more emerging every day, like with the track TBI and other prospective studies that are looking at acute injury and then following forward. And those studies that obtain data on some of the biomarkers, some of the so inflammatory biomarkers, and say the tau and the other kinds of biomarkers, are probably going to allow us to do a better job of that. I don't know that we're quite there yet, but I agree wholeheartedly that these course, classifications of mild, moderate, severe, penetrating are pretty difficult. I do think also that a study is needed to look at the question, your first question, which is, when you have somebody who's in, say, this trajectory of decline, what kind of I think it's the engagement in therapy and the cognitive rehab over time would allow you to, what that engagement and treatment pattern looks like. I have a colleague, Jacob Keane, who's got a study that's actually trying to get at the answer to that question by doing a very close, it's a very data, it's boots on the ground, folks in clinical care entering data about the treatment provided and the number of treatment sessions people have. I'm not sure if it has engagement in treatment within that data collection, but I could connect you with Jacob Keane if you're interested. And his study is actually designed to examine that question specifically. So the good news is somebody's looking at that in actual clinical care, like kind of a very pragmatic study.
Thank you. So this next one is a comment and a question. Great presentation, Dr. Pugh. How did you identify TBI severity using CTBI-E data?
So we did that based on the duration of the self-reported duration of loss or alteration of consciousness. And so people who reported a self-reported loss of consciousness of 30 minutes or less were mild, and greater than that were moderate or severe. and the alteration of consciousness of 24 hours or less was mild, and greater than that was moderate or severe. They didn't really have enough gradations to parse longer, more severe from that. And those are consistent with the VA DoD guidelines for TBI.
Thank you. Next question is, has the military contracted to identify biomarkers via blood sample done at the time of trauma to identify TBI? Is that accurate?
I don't know. That's a good question. I will look, but I don't know the answer to that one.
Thank you. I have a question for clarification. All of the 5-year data was extracted from VA med records using ICD diagnosis codes, correct? If so, note that cognitive, vestibular, and oculomotor symptoms are most commonly just included in the TBI diagnosis.
I agree. And yes, they were. And I do believe, I agree with you that that's a big limitation.
Okay, thank you. And we have here, when considering effects of treatment, please look at multiple disciplinary aspects of treatment, mental health, PT, speech, OT, pain management, audiology. I think that was more of a comment. Okay, last one. Why do you think historically resolved around MTBI group has such a high substance use disorder and PTSD probability?
I don't know. It's one thing. This is the group that we haven't really had it. We didn't really have a chance to look at in much detail because this study was really designed to look at mild TBI and no TBI. And we did the kind of the stratified analysis because I was interested in that. But that, I'm curious what others think. I think it could be that they're not engaged in care because they don't have, kind of persistent post-concussive symptoms per se, but it might be that the TBIs, and it might be that they've had multiple. They might have had blast-related. They might have had subconcussive events where, like shooting the big guns next to their head, that lead to TBI-related, mild TBI-related issues that aren't picked up in the screening, and then they either A, could fall through the cracks and don't get the evaluation that others do, or B, there might be, I'm not sure, I'm not sure about the PTSD. It could be that in mild TBI, there's a large risk for alcohol use disorders, those kind of substance use disorder post TBI. So I don't know the answer to that question, but it's one we need to find out.
Thank you. This next one, I believe refers to, is a follow-up on the question regarding the blood sample. FYI, this is what I heard about, but wondering about your thoughts. Biomarker laboratory assay blood tests for TBI will greatly enhance the ability of DoD medical personnel to objectively assess service members who suffered a suspected TBI.
I think that's great. I think it'd be a great addition. And it would also help once those data are collected and prospective evaluations are done, you could identify people with certain patterns very early on who are more likely than others to have longer term effects. And you could help, you could do, figure out some kind of treatment to mitigate risk. There's a lot of good treatments out there. We're not sure what to use with what person at what time, I think is the problem.
All right. Thank you, Dr. Pugh. That is all the questions that I'm seeing right now. We still do have some time left. So audience, if you have questions, please send them in. While we wait a few minutes for that, Dr. Pugh, do you have any, do you want to make any closing comments?
I don't really have anything much to say other than thank you for being here. And if you have any thoughts or questions or comments, you can always contact me at either email that's on the slide.
Great, thank you. I don't see any more questions coming in. Dr. Tapama, would you like to make closing comments as well?
Well, yes. Thank you, Mary Jo. It has been one of our world record attendances at 127. So your message has gotten out widely, and many of the provocative questions certainly go to the use of these 5 different phenotypes of TBI to possible investigation of therapy. Mary Jo is very busy, but I encourage y'all to be in touch with her. And thank you very much, Mary Jo.
Thank you.